The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, you have Katie and Anthony. We're going to go ahead and hold on for just another minute and then get started officially.
Okay, Katie, I'm ready if you are. Or do we not have that many people on the phone? Or can you tell? Sounds like we only have 2 people on the line, so we'll keep waiting.
Anthony?
Yes?
Oh, this is Jeanette. Sorry, I wasn't sure in the past. In some meetings, you needed an audio pin, and I didn't see one for this meeting, so I just wanted to make sure you could hear me.
Oh, yes. It sounds like we only have 2 people on the line, so we're going to wait a few minutes before we.
Okay. Thanks.
Can you hear me?
I can.
This is
yes.
Helen at Pacific Source.
Oh, okay. Thank you.
I'm just
Anthony,
kind of
this is Kathy Mers, too.
So for people who just called in, this is Katie. I'm going to actually share my screen to go over the presentation to the advisory committee. So if you want to follow along, then there's a link on the agenda that Anthony sent, and you can, I think it tells you to like register, and then it will send you the actual link to the webinar. So you'll want to do that so you can follow along.
Hey, this is Tim Sweeney. Oh, sorry, this is Tim Sweeney from OHA, but I'm going to be on mute most of the time.
Can I use it?
I heard Jeremiah and Tim.
This is Aaron Mull.
Yeah, this is John Mullen. I don't see a link though to the webinar. I might not have been getting all of the emails because of the change in my employment.
I'll send it to
I
you right
can't
now,
get
John.
the link to work.
I can certainly follow along from the handouts too. I got the handouts.
That's fine. I'll just make sure to tell you what slide I'm on.
Okay.
This is Jesse O'Brien. I'm on the call. Hi, everyone.
This is Janet
Barbara.
Bauer.
This is Sean McNulty, Project Access House, here as well.
Janet Bauer.
Doug,
What policy?
I heard you, Janet. Doug,
Okay.
are you on? Did I hear you, Doug Barber?
Yes, I'm here. Thanks.
Okay, thanks.
Hey,
So,
it's Lori Long with HealthNet, also on. Thanks.
Thank you. So I've got Helen, Kathy, Jeanette Taylor, Jeremiah, Tim, Aaron, John, Jesse, Janet, Sean, Doug, and Lori. Anyone else on the line?
Gary's on.
I'm sorry, who?
Gary Leslie.
Oh, Gary. I know you. Okay, well, sounds like we have a fair number of people. Why don't we go ahead and get started? So I, again, want to thank you all for participating today and for participating in the last several meetings that we've had. I appreciate the time that you put into attending these meetings and your thoughtful consideration of the issues that we've been dealing with. I know that it's not always easy or exciting to make these meetings. So with that, we'll go ahead and I'll go ahead and talk about the agenda real briefly. I wanted to start with public comment, and since this is our last meeting, I thought an extended public comment period might be a good idea. And also, in the case that we didn't get any public comment, we didn't need to extend the meeting waiting around for the public comment if it was never going to come. So that's why I put it first. After public comment, and obviously we won't wait till 2:05 if no one's on the line, but if they join late, we'll have them go ahead and submit public comment at an appropriate time. And then after public comment, Katie's going to go ahead and give her presentation that she drafted that she plans to, or that we plan to give to the Marketplace Advisory Committee. And then after that, we'll have questions and discussion regarding the presentation. Then Barry's going to talk a little bit about the draft response to the McCarthy letter, which you should have received with the agenda. And then I'll briefly go over next steps, and then we will adjourn. So any questions about the agenda before we get started? All right, is there anyone on the line who wanted to provide public comment?
Hi there. This is Kim Fredland, and I didn't want to provide public comment, but I came in just a couple minutes late and so missed the introductions. I'm from the Department of Human Services.
Oh, okay. Thanks, Kim. All right, so it doesn't sound like we're going to get any public comment, at least now. Just so you're all aware, we have the public comment period is the official public comment period ends January 27th, and we'll be taking comments in writing in case, people, that's the preferred method of public comment for some people. So with that, we'll go ahead and get started with the presentation, and I'll turn it over to you, Katie.
Okay, so I'm going to attempt to show my screen. Oh, sorry, I have to make myself the presenter. There we go. Okay. So it should be showing my screen now, hopefully, for you guys. So this is the draft report that I will be giving to the subcommittee. So I want to give it to you guys so that you can correct me if I put anything incorrectly, and just make sure that I got everybody's thoughts in there, so that when we tell the advisory committee what we talked about, that I tell them the right thing. So that would be the title slide. I feel like that's pretty self-explanatory. So moving on to slide 2. So the subcommittee assignment, Anthony helpfully pulled this language out of the actual, Anthony, this was out of the bill, is that correct?
Yes.
Yes, the statutory language. So it just says identifying federal provisions subject to waiver that are expected to improve the delivery of quality health care to Oregonians, including but not limited to alternative approaches for achieving the objectives of the basic health program. So if no one has anything to say on that, I can move on to the next slide. So then I just wanted to kind of let them know what we did at our subcommittee meeting. So, we came up with the issues, and we mostly focused on vulnerable populations, but not entirely. And then, we went through and refined the ideas in the matrix and made sure that we really had presented them correctly, and then we prioritized the ideas. And so then I will tell them about the prioritization categories, and I'm just going to do it very similarly to the way that I did it with you guys at the last meeting, is just kind of explain what the categories are, and then I'm going to go through it just like I did where we talked about the first two that we could do using our existing authority and funds, so we can increase use of the coordinated care model in our QHPs, and we can do that through our contracting process, or probably a fair number of the carriers are actually already doing some of these things, and so it might be that we want to ask them to do some reporting on them, or ask them to maybe highlight them a little bit more for the people who are purchasing their plans. And then the second is to continue to expand the outreach to the individuals who are eligible for the silver plans with the cost sharing reductions, but who may be buying the bronze plans by mistake, not understanding that they're going to be on the hook for a lot more cost sharing with those bronze plans versus the silver plans that have a slightly higher premium, but they would pay a lot less to go to the doctor. So does anybody have any comments on those first two? Okay, then moving on to slide 6. Oh yes, go ahead.
So I just want to be clear, are you recommending to the marketplace that they increase the use of coordinated care models in QHPs, or is it just saying that we could do that?
So that is a good question, and one that I wanted to ask at the end, and Barry might need to weigh in on this too. I assume that this is all us making a recommendation to the advisory committee of these are things that we think is important, and then the advisory committee would be the ones to actually decide whether we move forward on things. Is that right, Barry?
Yeah, that's right. I think really this is really the flavor I've gotten from the committee, although people are, this is a great time to have this discussion if I'm wrong, is that this is really the things that we've identified that are issues in Oregon that are important, and this committee has gone through and then done one step further, which is to prioritize them, to say, gee, if you could only do such and such, this is how we would prioritize them. And so we're really taking this kind of priority list to the advisory committee to have them kind of think through what could they then move on to recommend to the legislature. But if that's not the right thinking, now is a great time to have that conversation.
This is John. That's how I saw this report. In other words, this is background to give the Marketplace Advisory Committee for them to be fully up to speed and to give you a sense of their interest and concerns moving forward. And then it's not until March that you actually report to the legislature, which would then, I would assume, have additional details and additional things that you might say, we could be ready to go on this if there were resources available, or we can do this within our existing budget, those kinds of things.
Yeah, so the reason I asked the question is, you know, we haven't really talked about what coordinated care is beyond using that phrase. And so, you know, I just want to make sure we're not making a I can't say that we're for or against coordinated care as discussed here because I don't know what we're talking about. And particularly when you talk about more reporting, we do a lot of reporting already. So that's why I'm raising the question.
And that's totally valid. And you know, we have always really worked hard with the carriers to try to find, like, are you, like, when I say reporting, I'm thinking more like, you guys already report things, we just don't get those reports, so is it something as easy as you can send us that report or something? You know, obviously, these are very kind of high-level ideas that would require some serious work to, you know, get into actually operationalizing them.
This is Janet Bauer. There is a definition of coordinated care that the Oregon Health Authority uses, and we perhaps could reference that for them so they're clear what definition we're using.
But this is the first I've heard of any discussion of that definition in this venue, if that's what I mean.
So, Erin, what would make you feel better about, like, how can I clarify it that would make you feel more comfortable?
I mean, I'm fine with it so long as it's not representing that we're specifically wanting to do anything like take our CCO approach and stick that on the exchange, or start reporting metrics that we report to someone else and start reporting it to Oregon, because without knowing specifically what those things are, I don't know if we're behind it. We haven't talked about it.
This is Jeremiah. As far as I understand it, getting the CCO model up into the marketplace is like one of the foundational tenets and statutes about CCOs. That's not anything new.
Yes,
but
at least, go ahead, Grace.
Thanks, Katie, and thanks, Jeremiah. I guess I was about to pipe in and kind of share what Jeremiah shared. This really has been kind of a foundational concept in health reform, I think, just because of the myriad of things that have occurred in Oregon. We've been a long time in getting here. If it would help build consensus and just give people time to help us develop that idea more, we could simply change the language to say, evaluate the use of coordinated care model in QHEs, or something that would denote that we're going to do further research, and as John Mullen suggested, we are going to be culling these more and taking more data and specifics back to legislature March 1st. So that might also be a solution.
That would be fine. Thank you.
I would be in favor of. I would be in favor of language that implies that we want to consider increasing the use and not just to consider use of the coordinated care model.
Yeah, I agree with Janet, and I would be comfortable with the language that's in there. Understanding to Aaron's concern is that these are not step-by-step implementation concepts. These are mainly the prioritized list of what we talked about in our subcommittee. And so we did have some discussion at some length about coordinated care models in this exercise as well as the prior task force. So it seems to me to be consistent. Now, whether there is a model that increases the coordinated care models in QHPs would be something that the legislature would have to buy off on, and there would need to be resources and rules and all of that sort of stuff, which I'm sure Aaron would and others would be engaging in that discussion. But I agree this is foundational, and I like the language the way it is.
This is Janet again. I wonder if making clear that our recommending the increase of use of the coordinated care models amongst QHPs does not imply any specific manner of implementing it, and that we are making this recommendation as a conceptual recommendation and not a blueprint for how it would be done. I know that this idea has been promoted by high level, at many, many levels for quite a while. But as a concept, without discussion of exactly how it would be implemented amongst QHPs. So
yeah,
one alternative would be to do a footnote or an asterisk or even a parenthesis at the bullet point that makes that qualification, and keeping the language as it is.
I would simply suggest that the sort of like the more caveat language belongs someplace closer to the beginning, a blanket statement, because there are other things that are listed here that don't have the nuts and bolts about how that would be implemented in any case. So I think it's true for a number of these things. So if we wanted to put language like Janet suggested someplace closer to the beginning or part of our discussions going forward, either at the beginning or the end, I think it would make sense rather than just singling this one issue out.
This is Anthony, and I just wanted to mention that the way that the marketplace works with carriers is through the contracting process, and we never just sort of drop requirements on the carriers without discussion and back and forth and opportunity to comment and to provide feedback. And our approach is not to burden carriers, overly burden the carriers with stuff that is just not related to things that they are currently doing or that they could easily implement or implement without much difficulty. So, Aaron, with that kind of context, I hope I hope that eases your concern a little bit.
It does, Anthony. Thank you.
So then are we okay with evaluate the use of the coordinated care model in QHP as our bullet point?
This is Jesse, and I think that we should call out actually wanting to increase the use of the coordinated care model, as long as we're clear about the fact that we need to do a lot of work to figure out what we could all agree on that would actually move the dial on that. And I think, you know, one kind of maybe obvious background point about this to make is that you know, the slides here are just a presentation. So Katie, who I assume is going to be the person presenting this to the Marketplace Advisory Committee, can just, while this slide is up, explain exactly this discussion that we had in the subcommittee and say, you know, there's some disagreement about what this would look like, and we'll need to talk it through, but at a high level, there's some agreement that this would be desirable, and that's been the case since the first days of Oregon's state-based health reform efforts.
I think that's a great idea, Jesse.
Perfect. So I will change this back to increase, and then I have taken some notes down in the notes part that I can use to help me communicate this conversation to them. So do we feel okay about this slide and can move on to the next one, or were there more comments? Okay, I'm going to move on. So then the next one is the things that can't be done due to healthcare.gov restrictions. And so this would be about allowing the undocumented individuals purchase coverage. And so then I did include in the notes that, that even though this isn't currently possible for Oregon because we use healthcare.gov, we like to keep it as an item for consideration as we adapt to future changes and possibly get our own health insurance exchange, or if healthcare.gov starts to have some different abilities, then we'd like that. So are we okay with that slide?
I would want to call out that this would not be establishing subsidies for the undocumented population, that it's just...
Oh, very good. Yeah, thank you, Sean.
Also, I was wondering if the family glitch might belong on this page as well.
So, Sean, we had included the family glitch in the, let me see, it's down here a little bit. So these are the ones where we could do it by 1332, or we could do it by providing a wraparound program. So I left it in here.
Do you have that as a solution for the family glitch? Because unlike the other programs where we were considering a wraparound, those other programs would be the state paying somewhere in the range of 5% of the costs, as opposed to the family glitch paying 100%, or
right.
100%, but the 30% actuarial value remaining. So there's just a big scale difference. I don't know if we discussed that part much, but it seems like the family glitch is a far and away much harder problem to deal with at the state level through a wraparound solution. It doesn't seem to be the same sort of wraparound subsidy. It would be creating a replacement for advanced payment tax credits, cost sharing reductions, and basically recreating the entire federal subsidy system on a state level, which is a few degrees of scale larger.
So I think that's fair. Do other people like that?
So the proposal is to add family glitch
to the list of things that can't be done with the current healthcare.gov.
If that's a proposal,
that would also require a state
marketplace
to be able to
create
a system to offer those subsidies. So that'd be something separate from healthcare.gov. Even if we decided to create it, it's a bit different than the wraparound thing where we'd be having people enroll in a program and then just getting the premium assistance part from the state, which is the wraparound structure. It would have to be an entirely state-focused thing if we wanted to do something for the family glitch.
Right.
Okay, I guess at this point in time, I want to just raise something that I don't understand about this report. One of the things that the charge was to look at basic health and come up with some alternative ways of achieving the same results. And unless I'm missing something, I don't see anything about the population below 200% at FPL or the legally present residents and the COFA populations. Am I missing something by that? Because I was certainly assuming that's a bedrock kind of discussion about basic health or any basic health alternatives. We're looking at populations around affordability and exclusion issues.
Wasn't that on a different slide?
So John, on slide 10, these are the things that where the solution might be provided by a 1332 waiver or state funding and wraparound program. And so the individuals under 200% are the fourth bullet, or excuse me, the third bullet on that slide. And I don't remember seeing anything about the COFA people who would have been. Say that again about the COFA people. They would not be eligible for the COFA program because they were over 138. Is that?
Oh, I'm sorry I missed that slide when I was going through this report. So I do see that it's there later on. I apologize.
COFA would be covered by the same immigrants under the 5-year bar.
Okay.
So they'd be lumped into that population.
So then, as I'm looking at this slide, I'm realizing that this is where I actually would have put the family glitch, and I must have missed it when I was creating the report. So going back to our previous conversation, so Sean was suggesting that we might want to put it on the slide about things that can't be done through healthcare.gov, but on the prioritization list, it is included with these other 4 things because we could theoretically provide some sort of, funding for those people to help them pay for coverage through the individual market. So do we want to add that bullet here where it fits on the prioritization list, or do you want to put it up under things that can't be done on healthcare.gov?
I have a comment about the healthcare.gov restriction slide and my interpretation of it when I read it, and maybe this will help answer your question. This is Kathy Mers. I'm an agent with Oregon Association of Health Underwriters. When I initially looked at this slide and it said cannot be implemented currently due to healthcare.gov restrictions, in my mind that meant the system restrictions with healthcare.gov, and that those were the things that were going on this list. Is that not the intent of this?
That is the intent of this, and so that's why the listing is kind of in the middle.
Yeah, and I would say it probably shouldn't go on it because, again, it revolves around how the subsidies are set and then the interpretation at the federal level of what affordable is. So I don't think this would be the right place to have it.
Which slide are you referring to?
The healthcare.gov restriction slide is more because of a systems issue.
Right, so slide 6. So, and I think that is a good point, and going back, like I said, to the prioritization list, the family glitch actually goes on slide 10. So I will add it there if people are okay with that.
Yeah, this is Jesse, and I think I agree. I mean, I'm interpreting the healthcare.gov restriction slide as being a list of things that we just literally can't do because we don't have direct control over them. And it seems to me like the family glitch issue is an issue where there are some things we could do, but they're made far more difficult by the fact that we don't have control over healthcare.gov. But they're not literally impossible.
Mm-hmm.
Right. So are we okay with that?
I'm okay with moving it to 10.
I thought that family glitch people could not purchase coverage in the marketplace.
They can purchase coverage, but without tax credit. For subsidies.
They can purchase, but without subsidies. Is that what you're saying?
Yes. So when it asks you, do you have employer coverage? If you say you have employer coverage, you can still purchase, but it just won't give you any tax credit.
Okay, I'm wrong. I was wrong then. That's good to know. Okay. Well, I'm perfectly fine with including it in 10. That makes sense.
Excellent. So I'm just going to wordsmith it here really quickly, and then we'll go back to the slide that we were on and move on.
So does that mean, in essence, that that slide is going to go away? Which slide is that? Cannot be implemented slide?
No, it'll stay because of the undocumented individuals.
I mean, I'd be perfectly fine dropping the slide entirely if it's not at all feasible. I don't think we need to.
I don't think, I mean, it just takes a second to just tell them that we would like to at some point look into allowing undocumented individuals to purchase through the exchange if and when that becomes possible.
Sure.
I agree.
Everyone okay with that?
I am.
Okay, so thank you for catching the family glitch. Sorry that I left it off the slide. So moving on to slide 7, these are the concepts that need more development to determine the best course of action. So John, please let me know if I missed anything on the Medicare issues. So the first one is the premium cliff for individuals who move from QHP to Medicare. And so then my little note for myself says, highly subsidized QHP individuals become responsible for a significantly higher amount of Medicare premium. And that's called, is that called the premium cliff? I know there's a cliff term, and I wasn't sure that I got premium cliff right.
Well, we've referred to it as a cliff, but it's not just premiums, it's also out-of-pocket costs.
Okay, great.
And just for what it's worth, people with disabilities in that second bullet, they would be happier if you said younger people with disabilities.
Thank you. Okay, so then my note to myself for that bullet says that young people who qualify for SSDI may not qualify for Medicaid, but may have limited income and would benefit from assistance until, or excuse me, it should be Medicare.
Yeah, they have a 2-year waiting period.
Right, so the 2-year waiting period is for Medicare or Medicaid?
It's for Medicare.
Okay, perfect. Sorry, I had Medicaid in the first part and Medicare in the second part, so I knew that was incorrect. Okay, so they have limited income and would benefit from assistance until the Medicare eligibility is met. So does that sound good?
What did you just say about the first bullet?
That was the second bullet. So young people who qualify for SSDI may not qualify for Medicare and immediately, but may have limited income and would benefit from assistance until Medicare eligibility is met.
Yeah, okay.
It would even benefit them afterwards as well, though, because if you're above the incomes where you're qualified for one of the qualified Medicare beneficiary programs or a SIPM, then you're still falling into that cliff area, and most people are might qualify for Medicaid while waiting to get onto Medicare, so there's some issues before and after on that. So.
Okay.
Mm-hmm.
Okay, and then we all know about the churn. So the transition between QHPs and LHP is just something that we need to work on some more. And then social determinants of health. You know, I think the committee is pretty informed on social determinants of health as a general concept. So does anybody have anything else they'd like to add to that slide?
This is Jesse, and I would just say, I think for the purpose of a presentation to the Marketplace Advisory Committee, this is great, but when we get to the point of reporting to the legislature on this work, we'll probably want to flesh some of this out a little bit. I mean, obviously, as the slide is calling out, these concepts need more development before we have specific recommendations, but I think we'll need a little bit more detail about what we're actually talking about just to convey the questions to the legislature. But maybe that goes without saying.
No, that's a good point, and I think, go ahead.
Well, I was going to say, Jesse, this is Barry. I agree with you, and I would say that we probably need to do a little bit more fleshing out now that I think about it, even for the advisory committee, just because this group is really so familiar with these issues. We all uniquely understand what we're talking about and probably even have a lot of statistics in our heads and data around what this means in terms of implementation, but not all of our advisory committee will either. So we'll have additional detail ready for that meeting as well.
Great.
Well, I'll just put a little note to myself, Barry, to add more detail.
What is it that you're asking the Marketplace Advisory Committee to do? Is it to approve this, or is it to accept the report with the idea that there'll be further work on it? Because then I think it may matter more or less depending on how much is riding on this particular recommendation.
So John, I'll certainly let Jesse, as the vice chair of the committee, jump in and correct me. But what we have planned to do is to take your prioritized list of the advisory committee to really be able to explain in detail why each of these issues is important in Oregon, and to provide some specific data around how many Oregonians are impacted, what an implementation program might look like. And I wish we could say we'd also have maybe budget numbers for implementation costs. We probably wouldn't have that for the January 26th advisory committee, but just really to give the advisory committee a flavor of the issues and the magnitude of their impact, and then to let the advisory committee decide whether or not they want to take some or all of these line items and go back to the legislature and say, hey, we really think these issues are really important, and we recommend that the legislature consider actually taking steps to resolve these problems for these Oregonians. So Jesse, I don't know if you have anything else to add.
Yeah, I think that's right, and I think I'm hoping that we can come up with some high-level recommendations that we can make to the legislature, and then they can provide some signals about which ones they really would like us to pursue and flesh out in more detail. But I mean, I think we also want to have some sort of report that just explains all of the things that we looked at. So you know, this report to the Marketplace Advisory Committee is at least kind of like a skeleton of that, I would think.
Okay, so are we ready to move on to the next slide? Does anybody have any further questions? Okay, so the next slide, so the advisory committee has had a presentation on 1332s, I think, Barry, is that right?
I'm sorry.
We're just going to do a kind of overview for them.
Oh, yes, I'm sorry, I didn't, the phone got jumbled. Yeah, just make sure the committee understands what is allowable and not allowable with the 1332 waiver.
So the things that can be waived under the 1332 waiver, you can get rid of the individual or employer mandates, or change the lower or remove the tax penalties for those. And then benefits and subsidies, that states can change which benefits or subsidies must be provided. And then exchanges in QHPs, the states can modify or eliminate QHP certification, to modify or eliminate exchanges for the vehicles for determining eligibility for subsidies or enrolling consumers in coverage. So those are the kind of areas that are allowable. And then in order to get a waiver, you must meet some criteria. So the first one is scope of coverage. So you have to cover as many people with your program that you're using the waiver for as would have been covered without it. Comprehensive coverage, you have to provide at least as much coverage as they would have gotten before the waiver. Coverage must be at least as affordable as it would have been without the waiver, and cannot increase the federal deficit. So those are our little overview slides. Does anybody have any questions about those? So then we get into solutions that may be provided by a 1332 waiver or the state funding and wraparound program. So the first one is reducing cost sharing for certain categories of care and bronze plans. So the federal government just released some new limits on bronze plans, which actually allows the bronze plans to be a little bit richer. So we might have some options here, maybe a change to the standard bronze plans. So last year we changed the standard bronze plans to require 3 primary care visits before deductible. So we might want to choose something that that we also require the standard bronze plans to cover before deductible, like perhaps urgent care, specified number of specialist visits, an ER visit. I'm not an actuary, so this would have to be, someone would have to look at this and make sure that things could fit within the actuarial value and not increase rates. But these are some just examples of things that we could look at. Otherwise, we could institute a COPA-like program where we reimburse for the cost of those
So does anybody have any questions on reducing the cost sharing for bond plans? Okay, and so then the next one is providing additional premium and cost sharing assistance for immigrants ineligible for Medicaid due to the 5-year ban. So again, that would be sort of a COFA-like program where we give them assistance.
Do we want to add in the COFA population here as well? Because I know the premium assistance program, however you categorize it for COFA, hasn't had as many people take up the program as was at least initially estimated. But I don't have any clear idea whether we have been meeting the needs of the COFA population. So if there's additional people that are in the COFA population that are either not signing up or don't find what's there affordable, I would just suggest we could add due to the 5-year ban, or for those with the COFA population with a permanent Medicaid ban. In other words, we could add it here if, unless people think that we're adequately covering the COFA population currently, and I'm not sure that's the case.
I'm wondering if that's more of a suggestion for the COFA Advisory Committee, because they have their own funding, and they may, if they're not covering as many people as they had predicted, then they would probably have more funding that they might be able to use for outreach, and that might be more effective in that scenario, in that committee. Thoughts on that?
The program we're proposing creating for immigrants would be anybody who does not qualify for Medicaid. The under 5-year bar is a good way to phrase that, but this new program would cover that same population, and you'd have a question of what to do with the funding that's going to the COFA population. Some outreach funding would make sense to preserve, but phrasing it as an expansion of the COFA program or something that conveys that
or the other thing, or the other thing is we could change. Oh, I'm sorry. Go ahead.
No,
I'm just thinking that language could be changed just to say assistance for legal immigrants ineligible for Medicaid.
Yeah.
Yes, I think that's right. And then would it be helpful if I put in parentheses would include the COFA population, or do you think that just confuses things more?
I don't think it's necessary if we just, we're talking about legal immigrants ineligible for Medicaid.
Excellent.
Maybe
so
lawfully,
no. Go ahead.
Lawfully present instead of legal might be better.
Whatever you like. That lawfully present is fine to me. It's just
so the bullet point now reads, says providing additional premium and cost sharing assistance for lawfully present immigrants ineligible for Medicaid.
Yeah. Good.
Okay, so then the next one is providing additional premium and cost sharing assistance for individuals under 200% FPL. So that was the original kind of goal of the basic health program. And so we have options. We could do sort of a COFA-like program for these people as well. It's just where that wraparound and the BHP-like part comes in.
Mm-hmm.
And then the next one is providing premium assistance for individuals just above the federal threshold for tax credits. And we had talked about how for those people who are above 400% FPL, the amount that they pay might still be a big chunk of their income. And so even though they are technically making more money and they should be able to quote unquote afford it, they might also benefit from some assistance. And then I added a bullet point for the family glitch, and it says correcting the family glitch to provide subsidies to families covered by employer coverage that is unaffordable for dependents. Are there any comments on this slide?
This is Janet. I haven't unfortunately been able to participate in a couple of the recent meetings because of my schedule, but I wanted to just ask a question about the matter of covered services. One of the things that we were hoping to do with a basic health plan was expand covered services so that the benefit package would be more like the Oregon Health Plan, which we felt was more appropriate for people at lower incomes, and specifically adult dental, but there were other issues such as medical transportation and I think vision as well. So I wondered if those issues have been taken up in our discussions recently, and if how those were resolved. I guess my basic point
about
is,
them. Go ahead.
Oh, I'm sorry. Go ahead.
No, go right ahead.
Oh, I was just going to say that, you know, in some, the issues as we saw it were not only affording the coverage as offered, but that the coverage in some instances, in some aspects, was not adequate or appropriate for the population we're targeting.
So I remember that Erin had made a really good statement about that it is hard to incorporate things like medical transportation within the way that QHPs are currently structured, and it's hard to put an appropriate price on that, and then it impacts rates. And so I think that there is a way that we can talk about that kind of thing, but I'm not sure, and maybe it could be a bullet point on the concepts that need more development. How do people feel about that?
Speaking for myself, I think.
Go ahead.
Oh, including the idea that the adequacy of the coverage is an issue still to be resolved somewhere in this presentation, I think is appropriate given all of the discussions that we had in the basic health group about better meeting the needs of people who have modest incomes, and we talked a lot about dental coverage.
We did talk a lot about dental coverage and less about non-emergency medical transportation, which is also a huge issue for lower-income people. So I'd be in favor of including it if we can.
And again, I guess to reiterate what was said before, when benefits cost money, they end up in rates, and if we don't eliminate a benefit somewhere else, those premiums do go up. So I do think this would need further discussion and development.
Mm-hmm.
I sure would.
Agree.
I absolutely agree. Mm-hmm.
Yeah, yeah.
There's also just the complexity of the essential health benefits package and the uncertainty about what that's going to be in the future.
Mm-hmm.
Well, you know, by the time the March report comes out, the Affordable Care Act will already be repealed and replaced, according to the President-elect.
He says a lot of things.
That's true.
So I'm adding a bullet to slide 7. So expanding QHP benefits to include, I don't want to say to include Medicaid benefits because they already do include many of the same benefits. Is there something, expanding QHP benefits to more closely mirror Medicaid? Erin, can you help me?
That would be fine, and I think that would be adequate. I think it's optional to reference specifically dental care. I mean, I think there wouldn't be any harm in saying, for an example, inclusion of dental care or something. But I think your general language good.
Is this something we're suggesting for the general QHP marketplace, or just for people on the lowest income rungs that may be covered by the program under 200% FPL and the immigrant population, or is this something we're proposing for the whole marketplace?
Well, this is Janet. I think that, you know, we were talking about it just for the basic health population. The charge that we had, I mean, you know, as we saw it, was to better meet the needs of modest income individuals. However, there is the larger question of general access to oral health care overall in Oregon and the state of our oral health and what's holding us back. So I think there's a lot to be discussed.
Dental coverage is available through the marketplace, but it's done separately, so there's definitely a question of whether or not these programs we're proposing would pay for a dental plan in addition to a medical plan. I feel like it needs to be attached to those programs, the discussion of this program somehow. I'm not sure if it would be a separate issue if we're trying to expand that on the marketplace as a whole.
So how about this? I will wordsmith that last bullet and send it out to the group for comment after I have had some time to think about it, because it's pretty painful to wordsmith with everybody together, and I really appreciate everybody's input and being willing to sit and go through this presentation. So I will do that and send it out a little bit later this afternoon, and then you guys can give me written comment, and then I'll send out the finals. Does that work for people?
I think that's terrific. Thank you.
Okay.
Yes, and I did send information about my email address. I can't readily access my Oregon Law Center email,
right,
so.
And yes, and I saw that. So I will make sure that I include your new email address, and thanks for highlighting that for me, John.
Thank you.
This is Jesse. I had one final question about this slide, which is I know that it's probably unrealistic to make specific projections about how much any of these things would cost, but I think it would be helpful for the Marketplace Advisory Committee to have at least some kind of rough sense of how much they would cost relative to each other, or you know, something like the order of magnitude of costs that we're talking about. So I don't know if there's some kind of like medium level of detail that could be provided on that. And I don't know that it needs to be on a slide, just if it's something that's presented as part of the overall presentation. I think that would be really helpful.
I remember Deanne Gilmore had done some back of the envelope math for both the TOFA expansion, the under 200 and the under 200% populations before. I think you might still be able to get that for us.
Yeah, this is very
for that. Yeah, I was thinking of who might have some stuff on that.
The BHP report actually has a lot of data about each of these scenarios or each of these ideas, so we'll be able to pull a lot of that out of that.
Excellent. I just remember a number of 9 to 10 million for the immigrant population from Deanne, but that was based off of the higher enrollment estimates for the TOFA population, so I don't know how that's changed.
Well, I will pull numbers out of the report, and then I can also have a quick conversation with Deanne, and she might have some additional stuff, but at least it would give us kind of a starting point. Okay, so did we get through the last bullet on this? So the family glitch to provide subsidies. So are we okay with slide 10? Okay, so then slide 11. So here are the recommendations. So please jump in, correct me, so that we can make sure that I'm really telling the advisory committee what you guys have recommended. So the first one is that we not seek a 1332 waiver at this time, but to remain open to it if changes to the ACA make it applicable to us.
Do you think that it would be helpful to have that additional kind of language there In other words, do not seek 1332 waiver at this time. If I'm receiving that report cold, but just sort of say, okay, well, we'll set all of this aside for now, which really isn't how it feels going forward from here. In other words, I feel that when you all have a chance to chew over it, work with the advisory committee, that hopefully in March you'd be talking about some ideas that would include may very well include a 1332 waiver if it's possible to do it off in the future. So in other words, I'm just thinking that statement sounds too definitive, and I don't actually recall us making that recommendation as such, but really focusing on the fact that there would be a March report that would follow this.
So are you recommending that we wait to see what happens with the new administration and then look at whether 1332 works for us, or are you recommending that we continue to look for things that we could use a 1332 on?
Yeah, I guess I wonder what the value of that bullet point is there. And in other words, the other bullet points are fine with me, but you know, in other words, again, for an advisory committee person who hasn't seen any of this but is relying on the reports from the subcommittee, I mean, is it necessary to have that bullet there? And again, I don't recall us making that specific recommendation.
Well, ultimately, this is Anthony. Ultimately, the House Bill 4017 requires us to report back on making a 1332 waiver. So we do have to have some sort of recommendation in there regarding a waiver.
This is Jeremiah. Just a double kind of piggyback on what John was saying, and this might get into a conversation about next steps. So Anthony, feel free to say, let's talk about that at the end. But part of that bullet point to me has to do with what this group is going to do over the next 4 or 5 months. And to John's point, it doesn't make sense to put that bullet point in there if we're actually going to think about whether or not we're going to have a waiver or seek a 1332 waiver, especially since that whole process is about to get rewritten. Or we can say, do not seek a 1332 waiver at this time, but this group will continue to evaluate the best way to proceed forward with an evolving 1332 process. So I'd be curious to hear, and you just let me know if this is jumping the gun, but before we agree that that's the right bullet point to have there, I think it would be helpful for me to know where this group is going in the future.
I mean, one way that we might address it is to rephrase it to say that, you know, the work group sees the option of a 1332 waiver as an opportunity to address some of the things, you know, some of Oregon's concerns. However, we're not clear on submitting one. We don't think Oregon is prepared to submit, has done the groundwork to submit something at this time, or something like that. Because I think it is true that we still see 1332, barring, you know, complete elimination of the ACA and this provision, as an opportunity for Oregon.
Well, I still would feel comfortable if it was, the bullet was eliminated or it was reframed to say, while the subcommittee does not recommend seeking a 1332 waiver at this time, it is important that the advisory committee and DCBS follow up with changing regulations and or new opportunities under waiver provisions from the federal government. Something, you know, in other words, again, to me, this just sort of would stop somebody in their tracks seeing this for the first time, in a sense that, oh, okay, when in fact, as Jeremiah pointed out, you guys are going to have a lot of work to do over the next number of months in getting ready for that March report.
Perfect. That's really great feedback and really helpful. So So I think because, as Anthony said, we are charged with determining whether or not we want to recommend to the legislature to that we should apply for the 1332 waiver in the March report. So currently, we don't recommend that we should do the 1332 waiver, but knowing that things are going to change, we want to make sure that we relook at our ideas and the new 1332 rules if they change them and determine whether or not that might be appropriate for us. So, and that's basically what I had written in my note to myself to tell the committee, but I appreciate that, my short bullet makes it not look like that. So that's another one I'm going to wordsmith, and I'll send that back out to you guys with the other one this afternoon for final comment, okay?
Can someone explain how the committee came to the decision not to pursue a 1332 at this time, given that the previous slide says that a 1332 could help address a number of problems?
Yeah, Janet, I don't recall us actually saying that. So that was the point I raised earlier, but saying, I don't know where this statement came from.
This is Anthony, and so I think from the very beginning, I don't know that we actually came out and said that we weren't going to seek a 1332 waiver, but there certainly wasn't any indication, at least that I understood, that we were going to seek a 1332 waiver. And I think the main issue is that we started out these meetings, and I think at every meeting since the very first meeting, with the understanding that things are really up in the air right now, and we don't know if there's going to be a 1332 waiver opportunity at all in the future, or what that's going to look like, or there are too many unknowns. So it has always been, from our discussions, my understanding that in the first report that we were going to give to the legislature, that we were, I'm getting some terrible feedback. If you could mute your phones for just a minute, that would probably help. But what I was saying is that first report was always my understanding that we were going to indicate that at this time, without knowing more, and if you think about it, that report's due in a month and a half, that without knowing more at this time, that there was no way we could move forward with a 1332, and that we just needed more information. That as unless I just have not been paying attention, that is the sentiment that I've had throughout these meetings. So I think that's where that bullet came from. But again, I could have misread things, but I think yeah, that's where it came from.
This is Jesse, and I think that maybe the point of misunderstanding, if there is one, is just that the way it's framed in the PowerPoint makes it sound more definitive, like there was a specific recommendation that we all agreed to, when that didn't really happen. I think that what happened is that we all recognized that it just sort of literally makes no sense to seek a 1332 waiver at this time, because we have no idea what the parameters of that program are going to be. But what we did is identify some areas where it could theoretically be helpful if the 1332 waiver process in the future will allow it to seek a waiver, and where we also have some options for state flexibility within the current framework of the ACA if we wanted to create a wraparound program. So that's my understanding of more or less where we landed, but I could also be totally mistaken.
Could we say that the work group recommends that Oregon continue to consider a 1332 waiver as long as that option is still an option? I mean, because I think it is true. We've outlined on the previous slide that it does provide us some good opportunities.
Well, if we feel like we need a bullet point there, that language would certainly be more acceptable to me.
That seems like really good compromise language.
Yes, I like that. I'm working on it, but I'll fix it up and make it better and send it out. So thank you. And I know it's really painful to wordsmith as a group, but I really appreciate everybody correcting me because I was trying to incorporate, but you know it's hard to get everybody's thoughts all down. So I will wordsmith that bullet and send it back out. So then the second bullet, I know we need to fix it due to our conversation that we just had about the coordinated care model. So I have written that the marketplace should implement the use of the coordinated care model in QHPs. But so maybe instead we should say that the recommendation is to look at implementing the ideas around the coordinated care model and expanding the outreach to consumers, and so not actually say implement the use of the coordinated care model in the QHPs, but begin work on operationalizing, you know, how we could further the coordinated care model in QHPs or something like that. What are your thoughts on that?
This is Jesse, and I think that's great. I think the word operationalize is especially helpful because it suggests what we really need to do, which is figure out specifically what that would mean operationally for the marketplace and for the carriers. I would also say that the current language sort of implies that the marketplace is sort of like implementing this for the first time as opposed to it being like a new set of interventions designed to accelerate progress that's already happening, or at least theoretically already happening. But yeah, I think that wording is great.
So as a carrier who has to actually operationalize something when we finally settle on it, I can't do that unless I know what it is, and I have no idea what it is right now. So,
Aaron, sorry, you totally broke up. Can you repeat that?
Yeah, sure. So the word operationalize to me implies that you know what you're doing and you're going to move forward with it. And I still don't understand how planning on folding the coordinated care model, whatever that is, into the existing potential health benefits package and you know, the benefit design that exists in the market. So I would kind of take the opposite perspective of Jesse and say we need to do something a little softer that says we need to consider what a coordinated care model would look like in the QHP setting.
So I think this may just be like a literally semantic argument, because when I hear the word operationalize, I think like turning it into an idea that can be implemented as opposed to actually implementing it. But I'm not suggesting that what we should say is that we are about to do something specific without providing the specific details of what that would be. What I'm saying is that we should take the steps necessary to flesh it out. So I think we're actually not in disagreement, but maybe I'm misunderstanding.
Yeah. So Aaron, how about if I say that the marketplace should begin conversations with carriers to potentially increase use of coordinated care model in QHP?
Yeah, that would be great. You know, when Orham came in, this was put on. You know, we were told that this was something that you guys were interested in, and you know, that we would be having further discussions about that, and that's great. But you know, other things have sort of taken precedence for obvious reasons, and we need to have those conversations.
Okay, great. And so then I'm going to split this bullet into two. So are we okay with recommending expanding outreach to consumers who may purchase bronze plans when they really should purchase the silver plans with cost sharing reduction?
Mm-hmm.
Yes.
Okay. And then, so then the last one is that we really think that all of the ideas are important, and so we'd like the advisory committee to include all of those ideas in the report to the legislature.
Just one thing on that final bullet. Yeah. You know, there are two reports that have been talked about. One is the one in March, which is in the legislation, and then there was a discussion about a July report. I just point that out just so that you may want to have that discussion as a Marketplace Advisory Committee to say there's a report in March, but we're also thinking we'll need to have a little bit more time, and we have already talked about having a report, say, by the end of session.
That is an excellent point, because I don't think, Barry, we haven't talked to the advisory committee about doing two separate reports, have we?
No, we have not.
Okay, excellent. Then I will add that right here. Are there any other comments about the subcommittee recommendation?
I would just say I want to thank you for trying to divine all of our complicated discussions and putting together a simple PowerPoint. That's not an easy task.
Well, thank you. I tried, but then, like I said, thanks everybody. I know it's super painful to do it like this, but I think it's been pretty effective. Does anybody else have any other comments on the slides as they kind of currently are? Okay, so I will rework that last slide about the subcommittee recommendations, and then I can't remember which other slide I have. I have a note to myself to rework. And then I'll send this report back out. It'll probably come out late tonight after my children go to bed, so you guys can see it and send me back any comments before we finalize it for presentation to the committee next week. So I think that is all from me. Thank you guys so much. I'm going to stop sharing my screen, and Anthony, you can take it back over.
Thanks, Katie. So before we move on to the next agenda item, I just want to see if anyone has joined the call to give public comment. Do we have anyone on the line who would like to give public comment? Okay, and then before we actually go to Barry's call, if I could get you all to mute your phones until you're ready to speak, that would be helpful. I think we're getting a lot of feedback, and it makes it hard to hear what you all are saying. So please do mute your phones until you're ready to speak, and hopefully that will solve the problem. So
this is Jesse. Just a quick point of order. The Marketplace Advisory Committee meeting is actually in 2 weeks, not next week. It's on the 26th.
Oh, good. That gives me even more time to make all the wordsmithing as beautiful as possible. Thanks, Jesse. That's a good point.
Thanks, Jesse. And so now I'll go ahead and turn it over to Barry to talk about the McCarthy letter, which, to my understanding, you spoke a little bit about at the last meeting.
Yeah, I feel like after going through that PowerPoint, which everybody, as Katie said, it's really nice that everyone's willing to take the time to do this, that I should tease you all that we're going to go through this 9-page letter sentence by sentence. But I promise we won't. This is the letter that we spent, I think, a little more than an hour talking about at our last meeting, and it was really, really helpful because we had not actually drafted the letter at that time. And so your comments were really helpful in thinking through the content to add to Pat Allen and Lynn Saxon's response. So you've all had the draft response for a couple of days, and I think there's a couple of ways we can approach this. I think if you have kind of high-level comments, suggestions, or if you want to use this time to discuss different ideas, that would be perfect now. If you have very specific either edits or additions, I would say send those to me and track changes by 5 o'clock tonight, because this letter actually has to go out in the mail tomorrow. Tomorrow is the day it's due. So we're kind of running out of time, but we wanted to give folks at least 2 or 3 days to provide feedback. So you've had the letter. I guess I would just open it up to folks who want to discuss the content or provide additions.
Mary?
Yes.
This is Kathy Merce. Can you hear me?
Yes.
Okay, so I just had kind of a high-level comment after reading it, and I thought it was amazing that you incorporated so many of the ideas from our previous meeting into it, and you said it a lot more eloquently than most of us when we were speaking them. But two of the points that I just wanted to bring up that kind of relate to my industry and the people that I deal with every day. There's a lot of concern in the insurance agency industry about the pressure being put on not only agents, but also consumers and the insurance companies surrounding the open enrollment date of January 1st. And we didn't address that at all in this letter, and I don't know if it's appropriate to do that, but the reason I thought of it was because of the recent legislation that had been passed to allow for these HRAs that employers can now be sponsoring to help employees pay for individual insurance. And because of the potential with that, you know, type of opportunity, it's going to push more and more people onto that January 1st effective date. And I can speak for my own agency and a lot of other agents that we can barely keep our heads above water come fourth quarter in trying to service our individual clients and a good majority of our group clients in Oregon with that January 1st effective date. So I just wanted to point that out, and I don't know if it's appropriate to insert that in here somehow, but it is a concern.
You know, Kathy, thank you for raising that. That actually is a huge concern and one that we have lobbied CMS about directly, just because I know they've been the folks who have decided to push the date up. I think it might be too specific an issue for this letter, but I absolutely can assure you that it's an issue that we haven't forgotten about and will continue to take up as long as you know, the plan is to continue having us use FFM and delivering healthcare insurance.
And again, it had come to my attention in reading through this letter only because you highlighted the new law on HRA, which again, I think in my industry, a lot of us are split on whether we're proponents of that or not. And so that's why I thought it might, you know, warrant being inserted somewhere around there or just being noted. But I do know that it's on your radar, and I just wanted to bring it up.
No, it's a good issue, and I really appreciate that.
How is that changing in 2019 when the open enrollment cuts down to 45 days?
It still doesn't move people off of that general effective date of January 1st on when all of the plans renew and when people are really targeting to get their insurance. It just shortens the tail end of it. It still starts right in the middle of Medicare open enrollment, and it still ends within, you know, 15 or 30 days of it. So it's just, and in Oregon, because we've been able to let our small employer groups keep their plans in a grandmothered state, most of the Oregon small businesses now renew on that January 1st effective date too. So most people in the insurance industry have all of their business renewing on January 1st.
This is Aaron Balls. On that same HRA issue, we're a little concerned about the suggestion that it would be a good idea to expand the allowance to premium support for individual plans to the large group market. And that's primarily because the large group market has a better sense of its claims experience, and particularly when they're self-funded, but even if they're fully insured. And unlike a small group plan that, you know, is on a community-rated plan, you know, they have a much greater incentive to you know, kind of dump employees into the individual market if they're expensive. And there's not exactly great guardrails at the federal level around, you know, classing employees and eligibility and all of that. So we think it could really kind of affect the stability of the market if large groups were to be able to do what the small groups are going to be allowed to do.
That's a really interesting point, Aaron. I'm actually going to have to think about that one for a little bit, because it's a really good point. Let me give that some thought.
Thank you. My only other comment, sorry, this will be really quick. My only other comment on the letter specifically is just in the the paragraph under the first question, it uses the phrases high value plans, I think, to describe a richer benefit plan, and then value-based insurance coverage to describe, maybe a managed care plan or a plan with a high value network. Using something like richer benefit might make it a little less confusing, and that's just sort of a technical nit. Other than that, the letter is really good, and I want to thank you for putting it together. I think you did a great job.
No, that's a great suggestion, and I will tell you, we had the word opacity in this letter at one point, and I finally had to sit down with one of our plain language communications people and just say, dear God, we really need your help. So I've been struggling with that high value plans, value-based insurance coverage too, because I don't know that I could actually explain in any reasonable way what those mean. So we can simplify that.
Okay, thank you.
This, John, I have a different point if we're ready to move on to a different point.
Yes.
And that is going to the second question. What legislative and regulatory reform should Congress, blah, blah, blah. And our response says reforms. And what I'm suggesting, for a variety of reasons, is that we not use the word reform when they're talking about things that could actually be quite disruptive. Later on, you use the word proposal. So if you said proposal should maintain coverage gains by the ACA and serve to stabilize. Well, in other words, there are probably a couple of other places in this letter where the word reform is used. When we're using it to say these are reforms we're suggesting, that's fine with me. But when we're answering a question from them and saying, particularly in regard to that second question, that and again, this is probably not worth the discussion I'm putting into it. I just don't want to convey the idea that we're wild about some of the ideas that are being talked about in Congress. And I very much appreciated the whole discussion about the block grant and capped approach and money. I thought that was all right on. So I'm just making that suggestion about looking there and a couple of other places where how we use the word reform.
That's very helpful, John, and that's where my replace all button on the computer will come in quite handy. So I can make sure we're consistent with that word proposal. Thank you.
This is Jesse. I have several comments, and some of them have to do with wording and framing, and I can send those via email. But I have some sort of general comments about the section on state flexibility. I feel like I understand what you're going for with this, and I generally think that when Oregon has the flexibility to do design benefit and coverage requirements and actuarial value requirements and that kind of thing, we do a decent job of it. But I'm a little bit concerned that the way this is written suggests that we're totally fine with the bar being comprehensively lowered across the country, as long as it lets us do our own thing in our own state, which is something that I personally am not okay with. And obviously, the state of Oregon can. The decision about what this letter says is not up to me, but I'm not cool with conveying that impression. And I also, on a couple of more detailed points having to do with that section, I think it is important. It could be important to say a little bit more about what it would mean to provide states with the flexibility to accommodate value-based insurance coverage, and how that's different from the way the EHB requirements currently work. Because I think if that was clarified a bit more, then it would be clear that we're not calling for lowering coverage standards. We're actually calling for the flexibility to make them better, to make them work better for consumers. And also on the the point about catastrophic coverage, I don't have a specific objection to the idea that the state should have more freedom to allow that sort of thing, but I think it's important to clarify that has to, for it to work for consumers, it has to take place in a context that prevents adverse selection by ensuring that there are policies in place to make sure that there are higher actuarial value plans available for those who need them, and that insurance companies can't compete against each other to offer the lowest level of coverage for the lowest level of price, because that's just going to drive the whole market down. And also on the point about on the last paragraph in that first section, it says that Oregon recommends that Congress maintain federal regulations and guidance for mental health coverage and preventative health services, and says that other benefit requirements should be delegated to state regulators. And I feel like that, and maybe this is the position of DCBS, I don't know, but it seems like that's implying that we're okay with not having requirements for all of the other essential health benefit categories, which, you know, Osberg certainly is not okay with. I mean, I think that we could benefit from having more flexibility to make the benefit requirements work better, but I'm not comfortable with entirely getting rid of all of those categories of coverage, because, you know, a lot of pre-ACA plans just didn't cover a lot of really essential services for people, and I don't want to take a step backward on that. So I'll get off my soapbox, but those are just a few of my thoughts.
So Jesse, it's funny because I've read a lot of the responses that other states have sent to this letter, and when we start to sound like other states from the South, I start to get a little concerned, just because I know that our values are different in Oregon, and some of the ways that we've answered this question, I would agree with you, doesn't feel consistent with, I know, the values and vision that we place on kind of health reform and specifically on health insurance. So I think while we all know that when we're talking about increased flexibility and consumer protection in Oregon, we mean that because we think that we can be innovative in meeting people's needs in a really aggressive way, but perhaps for reduced pricing. And I think the way it might read is rather that we just think that nationally more flexibility would be helpful just in terms of reducing premiums. And so I guess if you have, this is where I would actually love your very specific help in terms of maybe doing some specific editing to make this a more powerful section, because I don't think it's as good as it could be. So anyway, maybe you and I can dither later on improving these 3 or 4 paragraphs and making it just still with the ability to really advocate for Oregon, because I think this is a little bit of an every man for themselves exercise at this point too, wherein we know we'll be fine in Oregon because, again, because of our shared values and interest in protecting people's health insurance opportunities, but I don't know that we're portraying it in a way that's going to be as helpful as we think. So maybe we can talk offline, because I could use your help.
Happy to make myself of service.
Put
myself at your service or something like that.
Thank you.
Any other comments? Go ahead.
I really liked nearly all of this letter. I thought that the positions that, you know, the responses to the questions were really consistent with our values. I was really glad to read through this. You know, I did have concerns about the first question, as people have expressed, and so I'm glad to hear that maybe it's not exactly what you intended. The only comment, and so I fully support you continue to work on it, so thank you. The one thing that I guess I did want to say is that there was a purpose in having a limited number of metal tier levels. And the purpose of that in the ACA was to simplify choice for people and to make it possible to do some comparison. So I think that, you know, if the spirit of changing meta level tiers isn't to multiply the number of levels and make it harder for consumers and more confusing, that would be fine. But it's just a caution about that, and I do underscore the other concerns expressed in this section, and thank you so much for your work on it.
Thank you. That we agree.
Any other comments or questions for Barry on the McCarthy letter? Okay, before we talk about next steps, I'll just ask one last time if anyone joined the call for public comment. Do we have any additional callers who wanted to give any public comment? All right, doesn't sound like it. So with regard to next steps, as Katie mentioned, she's going to do some drafting on some redrafting on the PowerPoint presentation and send that out to you all for your comments. The meeting, as Jesse mentioned, is the meeting of the Marketplace Advisory Committee is on January 26th. At that time, we'll be presenting the PowerPoint presentation to the Advisory Committee. Katie, when should people get their comments back on the revised PowerPoint? Katie? So when Katie sends out the revised PowerPoint, she'll include a date by which to get your comments in.
I had myself on mute. So yes, I just need
no
to coordinate with Barry to find out when Barry needs the final. So I will put a date on it when I send it out.
Okay, great. So we'll be presenting that to the Marketplace Advisory Committee, and then we'll be soliciting feedback from the Marketplace Advisory Committee, including how they would like us. We're going to propose that we, and I thought there was some talk about this at the Marketplace Advisory Committee of doing two reports, but I maybe have misunderstood that. But we're going to ask them about submitting a report in March and what recommendations they would recommend that DCBS make to the legislature. Taking their feedback, we'll then draft the report, and we'll send the draft of the report to both this subcommittee and the Marketplace Advisory Committee for final feedback, and then we'll submit the report to the legislature. And then from there, it's kind of a wait and see approach. So we'll you know, the legislature may weigh in on a report and have further instructions for DCBS. We may know something from the new administration about, you know, the viability of 1332 waivers, whether or not that they're still going to be allowed, if they are allowed, if there's some other process for obtaining those waivers. If there is going to be, hopefully it'll be something much less onerous. But our next steps after the report to the legislature really depend on what we find out from the new administration and what the legislature directs us to do, if they in fact direct us to do anything. But once we have that information, then we need to determine, that will determine whether or not, you know, this subcommittee is resurrected or not. But we'll at least have some some communication after we have that additional information. And then there will be the idea is there will be some final report by the end of, or by the beginning of July to submit to the legislature. And again, the contents of that report depend a great deal on what we find out in the intervening months from the new administration. So any additional or any questions or comments about the next steps?
This is Jeremiah, and I just wanted to say thank you all for your work. And I've talked to a few people in the legislature kind of about what we would want to do as far as next steps go. So to me, it may seem prudent to wait for advice from the legislature about how to talk about this in the upcoming months. And I also wanted to give a shout out on that letter. I thought the Medicaid part of that was really well written, and everything very much stayed within the bounds. And so I thought it was great. That's all.
Thank you, Jeremiah. Any further comments or questions about next steps?
I just want to say, this is John. This is my last meeting with all of you, but I'll be paying attention as a citizen advocate. So I wish you well. Look forward to seeing the March report when it's available. You have my contact information, but I just want to wish you all well in what is bound to be a tumultuous 2017 session. But hopefully the values that we put forward here will be a guide for legislators making decisions going forward about how to extend healthcare coverage for those who need it.
Thank you, John. Any other comments or questions? Okay, so again, on behalf of the department, I just want to thank you all for your time and your input, and your thoughtfulness, and your consideration of the issues that we've been dealing with, and we really do appreciate it, because without you we couldn't do what we're supposed to do. So we very much appreciate it. And with that, I'll go ahead and adjourn the meeting. Thank you all so much.
Thank you.
Thanks, Anthony.
Sure. Bye-bye.